Dr. Eric Janssen is a board-certified orthopedic surgeon specializing in sports medicine with an emphasis in knee and shoulder surgery. He practices at SportsMED in Huntsville, Alabama, and recently presented a program entitled, "Why Does My Shoulder Hurt?" We've provided the program in 3 parts. This video contains part 3 of the program. It includes traumatic injuries to the shoulder, strains, tears, dislocations, instability, and fractures.
So now we'll get into the traumatic stuff, the muscle strains, the tears that we see, and we'll start with the long-headed biceps tendon. If you look at that picture on the right, we call that a Popeye muscle, and what happened is that they tore that biceps tendon, and then that kind of rolls up down the arm right there. They still have the short head attached, and it looks real funny, but actually they can function pretty doggone well with this. And I had a bodybuilder one time, probably about 15 years ago, had that happen. He liked the way his looked so much, he wanted me to release the other side, and I said, "Ooh, I don't think that would be ethically possible for me to do that." I don't know if he found someone else to do it, but he never came back after that. But you know, as a bodybuilder, he lost all his symmetry, so he was a little upset about that. And we talked about pulling him back up and fixing that, but he didn't want to go that direction. They're very easy to make on a diagnosis. You know exactly what's happened there. The question sometimes becomes, well, does the patient have some other pathology like a rotator cuff problem? Because sometimes they'll exhibit that, so you do want to get an MRI on a lot of these patients. And 90% of the time we can leave that alone. They lose very little strength once you put them to rehab. It continues to look a little funny. The only reason to go back and operate is they keep some cramping or something like that. So sometimes we have to go in the front of the shoulder and dig that out and reattach it up here. You can't pull it all the way back in the shoulder because there was a degenerative segment in that allowed it to tear to begin with, and you can't over-tighten it. Sometimes we'll go in arthroscopically, and you know, if you have a tear that's almost complete and it's giving them a lot of pain, we might just release that, or we might reattach it. On the MRI, I don't know if that shows real well. The one on the left, up to the very top there's a little groove up there, and sometimes we can see that on the MRI the biceps tendon is missing from that, so we can confirm that's torn. The one on the right you see there, sometimes we can see where that biceps tendon actually is flipped out of its groove, and then we know we've got a tear in the subscap tendon, so that has to be fixed. You can't leave that there. And I've even had those biceps tendon flip past the muscle and go all the way down in the joint, and once again you can't leave it like that. So with certain injuries and certain findings on exam, you definitely want to get an MRI to figure that out. When we look inside the shoulder joint, that picture on the right is an arthroscopic picture, and to the top where that structure comes out, the socket's on the bottom, the ball's on the top, you can see all the damage and all the fraying in there. And a lot of times we'll see that as a secondary finding to going in and fixing the rotator cuff. We might debride that and shave it, and they tend to do very well. If it's been a big enough problem, once again, we may release it, or we may fix that, where we can fix it with a little screw up against the bone right there and then go from there. So those are the options: debriding it, fixing it down, or just releasing it in some patients. A lot of controversy in that. I got back from our main meeting in Baltimore, and nobody has the right answer of exactly what we want to do with that. So there's a lot of leeway in how we treat that. They all seem to do pretty well when you do that. You'll hear about labral tears. Baseball season's over, but these pitchers, very common to see that. We'll see it locally here in the high school and college kids. Usually it's in the older collegiate or professional athletes, but what happens is that where that biceps tendon attaches on the very top of the socket there, as you look at the picture on the right, that biceps tendon can pull that labrum loose into there, and it doesn't really heal, so they'll keep pain that radiates down the front of the shoulder. It can be traumatically induced. It can be atraumatic from repetitive throwing or activities, but it can be a real problem. We'll diagnose it on an MR arthrogram. In other words, we'll put dye into the shoulder and then do the MRI. And here you can see the humeral head or the ball on the left, the glenoid socket on the right. As you look to the very top of the socket, we see that dye kind of leak right up underneath there, and that's a very diagnostic test. So if we see that and the patient's symptomatic, usually we'll go in arthroscopically and we'll repair that. And here you can see where we've sutured it back down. The biceps tendon's on the right. You can see the little sutures on the left. And we can go in arthroscopically with these little dissolvable tacks, stick them in the bone and attach the suture that way, and then tie that back in, and that'll heal down. So it does very, very well. Sometimes in an elderly patient where it's a little frayed and beat up and degenerative, we might just debride that, and that can do real, real well too. But in a younger, more active patient, you do want to fix that. Rotator cuff tears. Here's an MRI. We can see that there's a defect right there where you can see fluid where that tendon should be pulled into the bone right there. That's going over the top of the socket into the ball. History a lot of times can be very diagnostic. Doesn't have to be traumatic, but it can be traumatic. And patients will really complain about night pain. That's one of the things that we hear almost universally with a patient with a rotator cuff tear. That they have a hard time sleeping, they wake up, it's just they can't get comfortable at night, and that's what brings them in. On physical exam, almost always they have weakness, but not necessarily. And a lot of times if we suspect it, we'll just go straight to the MRI. Because the size of the tear, or if they have a tear versus a strain, can be very difficult to tell. So, we can get a history, we can do this physical exam like I showed earlier to check the strength, and then to tell the severity, how bad it really is or how bad it's torn, is very difficult to tell. So sometimes we'll see a patient just had a strain and they act like they can't lift it at all and they might have a huge tear. On the other hand, we may have someone with a huge tear that compensates real well and can lift their arms. So we really want to get the MRI to know the extent of the damage when we look at that. And we'll talk about partial versus full thickness tear. Partial just means that if you think of that tendon coming in multiple layers, that a couple of the layers may be damaged and frayed, but the rest of the tendon can be okay and still attached. So in that picture on the right, arthroscopically, that's a picture of a partial tear where it looks like you're in a cave and you got everything hanging down like that. There's a lot of fraying on it, but there's not a hole all the way through, so it's still intact, but it can be very, very uncomfortable. So with strains and partial tears, we'll try to manage that once again, the normal anti-inflammatory, possibly an injection, physical therapy, all those sort of things. If we can't get those better, then we'll go on and consider an arthroscopy, just like we would a full thickness tear. If you have a full thickness tear, it's kind of game over. We tell the patient, if you don't fix that, this isn't going to get better, and if that tear size progresses, it gets harder to fix, results not as good, more likely to re-tear. So if we've got a cuff tear, we really want to fix those early on. How we do that, if you're looking here, the picture on the left, that's a real inflamed. You can see the redness in the back side of that cuff right there, but you should not be able to see down past the ball into the socket right there. So that's a very large tear. All that tendon tissue should be pulled up on the bone. And you can see how frayed it is kind of, but we do pull it up and we put either a combination of suturing it side to side, or we may go ahead and put little anchors in the bone to anchor the suture in and pull it back into place. And the good news is over 90% of the time these things will really heal in very well and do very, very well. But there is a certain number of them that will re-tear, and mostly it's probably because of the healing capability in that area. So you may hear of things like we've tried using PRP injections, other things to stimulate a better healing response. I know stem cell, all that kind of stuff is going to be looked at, and how can we improve the results of those to heal. Sometimes we'll get a patient that comes in, an elderly patient, they've had pain for years. You just look at them and say, boy, this is a rotator cuff tear, and it may be a bad one. That MRI on the right, you'll see that ball almost going straight up out of the socket because there's no rotator cuff to hold it in, and that's a bad problem, and we don't have great options for that, but we can certainly make it better. The one at the bottom, treat the symptoms only. A lot of patients will say after we give them the whole spiel about the three above, hey, I'll go home, leave me alone. But one option is to go in there arthroscopically and try to repair it, and a lot of times we can. I'd say 50% of the time we can. There's a pretty high re-tear rate though, because we're just stretching everything so much to get it there, and if that cuff hadn't been attached for years, then it's not the healthiest of tissue either, and usually these are older, less active patients too. So we may just bail out if we can't repair it and just debride it, and a lot of times, 50% of the time, if we can't repair it and we debride it, they'll feel a lot better after PT and say, hey, I can live with this. We can do, and I'll show that in a second, a graft jacket or a reverse total shoulder. And I'll show those in just a second, but I want to show you a difference in exam. This patient, before I roll this video, the left shoulder, what you'll notice is there's very little function in her at all, and she has this rotator cuff arthropathy where she has no rotator cuff to control the shoulder and elevate and use it, and she had this on both shoulders. We had to put a reverse total shoulder, which I'm going to show you in a minute, into the right side. And you can see it's not a normal shoulder, but functionally, boy, she's done very, very well. She's come back and had the other side done since, and she's doing just remarkably well with that and very happy with it. But here you see the right side, that's where we put the reverse. The left, she can't get that arm up at all. Come on, get that up. Come on. I can't. And there you go on the right, she can throw it up there and hold it, but that left, she just cannot pull it out. And that's very difficult because you think of daily activities, just having to reach out and grab something on a hanger or out of a shelf or a cupboard, even trying to put your clothes on or to go to the bathroom. I mean, if you have two shoulders like that, it's almost impossible, and one is very, very difficult. So that's what a rotator cuff arthropathy looks like, and it's very, very debilitating. In a younger patient, we may try to fill that defect, where we've got that graft jacket listed. We can use a dermis type of material. It's it's an allograft from a patient, and we can take the deeper layer of the dermis. It's pretty thick, and we can go in and put a patch on that. And we've got about 40 or 50 patients we've done that to, and we can really improve them quite a bit. Normally we want to do that in someone 60, no older than 65, because we know as you get older and older, the healing capabilities get less and less. So we usually try to reserve that for younger patients. We'll have patients in their 40s, things like that, who just have huge tears and we can't fix. And typically this works pretty well. What happens is once you put that in a defect, the body kind of grows a blood supply into it and reincorporates it as its own tissue. It may not be as good as it is the original, but it's a lot better than not having it. And then finally, for those patients, we can use this implant. Was designed by the French. They've done some really neat things around the shoulder. But it's called a reverse total shoulder. What they've done is they put the ball, as you look at that X-ray on the right, we put the ball into the socket side, and we put the socket on the ball side. We reverse what we do in a regular total shoulder, and that keeps those two engaged so that they can use the larger muscles like the deltoid to pick and lift the arm up, like you saw the lady doing in the video that we showed right there. Very good operation. Ligament instability. Common, particularly during football season right now, we'll see a number of dislocations. I've had to reduce 2 guys on the field this year where the ball and socket comes dislocated, but the other joints that we talked about, the AC and the SC joint, that can happen with it as well. Most times 90% in the ball and socket joint, it will come out the front, about 5% out the back, and the other is called multi-directional, meaning it goes in multiple directions. And what happens is that we get a combination of a tear once again in the labrum where the ligaments attach this time instead of the biceps like a slap lesion. We can also have bony injuries. When that ball rolls up over that socket and it engages hard enough, you can damage the ball and you can damage the socket, and those can be quite unstable injuries when that happens. If they've been dislocated or we suspect that they have instability, there are ways we can provocatively check the exam and try to figure that out by trying to pull the ball out forward or backwards. A lot of times they'll be apprehensive and we got a good idea. Or like this lady on the left, we can pull down on the shoulder and you look like, boy, that ball almost came completely out of the socket. She's multidirectional. She's got very, very loose ligaments, and that can be a problem for some patients. Test on the right, we'll try to push them out front and back with them there like that. And this is what we might see in the office, and this makes it pretty easy to diagnose. This is one of our patients. And we'll get a look at her back, but right here, she just jumped back into joint, you can see there. So we'll push her elbow forward, which will push her out the back a little bit. She's not completely out, but as we come back and put her back into the joint, snap, you'll see it right there. And she just, had a little injury. I can't remember what she was tumbling with one of her friends, or she was babysitting, I think, and she came in and said, boy, my shoulder's killing me, it's coming out of joint. So she obviously damaged the back of her joint with the labrum and the ligaments, and not many patients will let you do that, so we had to video that. I called Susie in the room real quick, and hey, you gotta get this. A lot of times when we see them acutely in the ER, we'll see this, the ball's completely out of the socket on the x-ray. And MRI, if they come in the office, they've had a dislocation. If you look just to the left where that ball and socket is, you can see the dye just leak right down the side of the socket right there. So that's where the labrum's pulled off. So these MR arthrograms, these MRIs with dye in them, are very diagnostic to help us and figure out where the lesion is and how bad it is. And sometimes if we have bony injuries, we want to get a CT because we might have to fix that to make this shoulder stable. We catch them on the field or in the emergency room. The most common way is on that left. Someone's holding counter traction with a sheet on them, and it's not a hard pull, it's just a real gentle, you try to relax them just as much as you can. The more you get the patient relaxed, the easier it is to get it in. Normally, when I'm on the field or wherever it happens, I'll try to lay them prone on the table and just let their arm dangle down and just gently put a little traction on it, and then usually we can pop that back in right there, and they don't have to go to the emergency room if we do that. So that's the most common way I like to do it. Surgically, once again, you got to repair the pathology. We'll go in with those little anchors that I showed on that picture and suture and reattach that and tighten up the ligaments. We have to, if there is a big enough bony defect, we have to deal with that as well. And once again, all that's done arthroscopically. Every day in my practice, someone's going to come in with back-sided shoulder pain once again. Is that coming out of the neck or is that directly from the shoulder? A lot of people will strain these muscles in the back of the shoulder blade, and they get kind of in a chronic pattern where the muscles don't start working right and the shoulder blade doesn't track right, and then it just goes on and on and on, and they come in very, very frustrated, and they're very difficult to treat. But if you can get the soreness down by treating it, and particularly with physical therapy, and get the muscles working right again, then you can get rid of that. But that is, that's a hard thing for us to treat sometimes when we see that. We'll see this, weightlifters in particular. If you look to your right on his chest wall there, you can see that dark area. That's a defect where he tore his pec. We'll see that with bodybuilders, weightlifters, guys that like to lift a lot. In my age category, try to overdo it maybe a little bit. And normally they don't completely tear that. They normally can get back without us having to fix it. There's been a little push to start fixing these a little bit more, but normally they do pretty well and can get back to their lifting. It's just that they have a defect there. And once again, if you have someone who's bodybuilding, boy, they don't like that because that asymmetry kills them. It knocks them out of their sport. The AC joint, very common. That's Sam Bradford on the left, kind of at Oklahoma when he had all that trouble. Of course, he's in the NFL doing just fine now, but usually a patient will land on their shoulder. We see this a lot once again in football season. If you look to this patient on the left, you can see how elevated that collarbone is right there, and that can be very disabling. You can see all the bleeding through the whole chest wall right there, usually an isolated injury, and you can see how high that collarbone rides on the x-ray on the right. So it's not hard to figure out what happened to that guy. Normally the lesser injuries, that picture up on the top in the middle, the arrows, we can see where there's ligaments that hold that collarbone to the acromion and then hold that collarbone down on the shoulder blade. And the combination of those ligament injuries, if it makes that collarbone too unstable with that shoulder blade where there's too much motion, then we have to go in and surgically correct that. If it's more mild, then we can leave it alone. So we can leave some of these elevated up a little bit, and they tend to heal and do real well. If we fix them, we either on the left, we try to go in and repair the ligaments and hold that down with something to stabilize it till it heals, or now it's become very popular to use donor tendons to make new ligaments, as you see on that picture on the right, and do what we call a reconstruction instead of a repair. Getting into the fracture type stuff, just to finish out, little leaguer's shoulder. Well, I've seen quite a bit of this in the fall. I'm not sure why, but we see a lot of travel ball players this time of year. And, this is about the time, man, the kids have been pretty successful at the younger ages. They're getting 12, 13, 14 in that age category. And then all of a sudden they're getting pitching lessons. They're playing on this team. They're showcasing with that team. And then all of a sudden they start having shoulder pain and they can't throw. And first thing the dad's right in there with them wanting to know how we'll get this better and they can throw this Saturday. It doesn't work that way. So it's a little disappointing to the parent, but it's very treatable. What happens is in kids, the growth plate's the weakest link. It's not the rotator cuff or the labrum or anything like that. So the kid's hurting, he's throwing funny, he can't throw, he's throwing a lot of balls, dad's not liking it, the coach isn't liking it, and so you just got to tell him, hey, this is an overuse injury, and you just got to shut him down till the pain goes away. Biggest thing again is education. You got to educate him and say, look, you're overthrowing him, you're going to have to back down, get out of this team, or not go pitching lessons as much, and it's just one of those things where they think, their next kid's going to be the next Tom Seaver coming up. So we put them on a little anti-inflammatory physical therapy. We want to get the motion back, the strength back. We want them absolutely as good as we can. And we'll put them back in a little throw-in program and build them back up before we turn them loose. But it's frustrating because they're going to be out for easily a couple months sometimes. And by then the whole travel season's gone by and he's the team's best pitcher, and we've caused them not to go to some travel tournament away because they couldn't win the tournament. But anyway, it can be a frustrating thing dealing with parents sometimes. Clavicle fractures, if you look at up there at the very top of the screen in the middle, you can see that the clavicle was broken, but it's often overriding, and we see this sometimes. These bad clavicle fractures, you got to fix those. You got to put a plate on it if they look that bad. So there you can see the x-ray on the right. There's the plate that we put on and the screws. If the clavicle is lined up, most of the time it is. If it's not a real traumatic injury, you can leave it alone. Those will almost always heal. But if it's displaced, shortened, then you really got to fix that, because that will mess with the shoulder mechanics, so you don't want to let that go necessarily. If it's open, you have to treat it with a plate and wash it out. This is more an elderly injury. You're talking more 60s, 70s, where you have an elderly patient that falls, lands on their arm, and they get this load of force that goes up the arm, and they break around that ball part. Those can be pretty substantial or significant injuries. The good news is usually they're not too displaced, so most times we'll let those kind of heal, and we'll keep them immobilized for about 6 weeks. At 3 weeks, they start to get a little solid. We'll start a little gentle exercise, and it's always a race against time. How fast can we move them, and can they tolerate that for us to get as much motion back? We normally will tell the patient, hey, you're probably going to end up with a little stiffness, but it won't be painful when it's all said and done if you'll do this rehab and get this strength back up. Occasionally, if it's too far out of place, we may have to, like on this picture on the left, put a plate and screws on it. Or if the pieces are so banged up, we may even put a prosthesis in, like that one in the center there, and try to reattach where the tendon's attached to it with bone fragments. Or on the right, may even bail out, which I've had to do before with a reverse total shoulder right out the chute. It's just so blown apart and almost like dust in there. But they typically will do okay with these, not great. Scapular fractures or the shoulder blade, injuries into the body of it usually are not a thing that we have to deal with other than just let them heal and then do the rehab. They typically do very well. If you have a high-speed motor vehicle accident, sometimes those can be displaced and have to be plated. The biggest ones we worry about is if the fracture goes into the joint itself. If that's displaced, then we got to fix that, because you can't leave that joint incongruent or you're going to get arthritis from that.
Also available on our YouTube channel, Part 1 and Part 2 of Dr. Janssen's program. Part 1 contains an overview, shoulder anatomy, and office exam for a shoulder injury. Part 2 contains non-traumatic injuries, bursitis, tendonitis, arthritis, and injuries to the neck and nerves. For more information on the diagnosis and treatment options of shoulder injuries, go to sportsmedalabama.com, or to make an appointment with Dr. Eric Janssen, call 256-881-5151.